Welcome to the last health assessment topic, which is neurological and musculoskeletal. I paired these two together because some of the things we assess in these body systems cross over, much like cardiac and pulmonary and skin. The structures of musculoskeletal include bone, muscles, cartilage, ligaments, tendons, and joints. There's a lot of stuff and more that we could assess in our normal nursing assessment. We're going to discuss the assessment fully in the musculoskeletal lesson later this semester. Our interview is going to focus on muscle strength, ability to do ADLs, and ambulation. We do want to ask them how they're able to care for themselves at home, how well they get around, and how do they do any exercising. We also want to ask about any trauma, broken bones, or surgery that can affect this body system. Asking about any pain in their arms and legs and back is helpful as well. So this part of the assessment can get very in-depth depending on what's occurring with the patient and can include palpating bones and joints and checking range of motion in all of our joints. However, that is a lot more than what nurses do as part of their general head-to-toe assessment. What we focus on for this body system, we actually already discussed it, so we're going to review it. I mentioned that we tend to do our neuromuscular checks while we are assessing cap refill and edema of the extremities. When we check the neurovascular functions, we're checking that each extremity has grip strength, pushes and pull strength, and asking if the patient has any numbness or tingling in their fingers or toes. We also have to have them wiggle their toes and their fingers to make sure they can move them, as well as checking to make sure they have sensation in their feet. When we check grips, pushes, and pulls, we are checking both extremities at the same time. So we have them squeeze both hands at once, push both arms at once, pull both arms at once. This way you can see if both sides are equally strong. Same with the lower extremities. If a patient doesn't have the same strength in both sides, something is wrong. Numbness or tingling in the fingers and toes is not a normal finding, and it means something is wrong with their nerves. They should also be able to feel us touching with our fingers and their toes equally on all extremities. If they can't feel us touching them on an extremity, there's an issue. So unfortunately, old age affects our entire musculoskeletal system. As we age, we lose muscle mass and strength, which makes older adults higher risk of falling. They also have decreases in their range of motion and changes in their joints that can cause pain and affect their ability to perform their ADLs. The spine starts to condense and they lose inches of height and they can develop kyphosis or upper back bend that looks like a hunchback. All right, now we're going to switch our focus just a little bit and we're going to look at the neurological system. So assessing the neurological system gets a little mashed up. We don't have clear-cut interview, inspection, palpation, auscultation. It's all mushed together. I'm going to do my best to break it up in a coherent way. So let's start with our initial inspection. The inspection we see when we walk in the door, and it's part of our general survey. When we walk in, what does the person look like? Are they wide awake? And do they turn to us? Are they talking to people in the room? Are they laying there with their eyes closed? Do they open their eyes to us moving around in the room? Do they open their eyes to our voice? Do we need to touch them to have them open their eyes? What kind of emotions do they have on their face? Are they moving their body? Do they look clean and bathed, or do they look like they haven't showered in a long time? These observations gives us clues as to what their neurological system is doing. When we're seeing if they're awake or have their eyes closed, we're assessing their level of consciousness. When we look at their emotions on their face, we're assessing their emotional state. And when we look at how they look, if they're clean or not, we're assessing their ability to do their ADLs. This is a very important observation for ED nurses. When we watch them move their extremities, we're assessing neuromuscular system. And we assessed all of these areas just by walking in the door. We didn't do any touching of any of this. This was all inspection. When we do the interview portion of our neurological exam, it can be very simple questions all the way to a full-blown neurological questionnaire, just depending on what's going on with our patient. Most nurses do not go in depth with a neurological interview unless they work in neurology, trauma, or the ED or ICU. We want to ask them about any history or current numbness, tingling, seizures, or muscle trembling. We want to know about any headaches or dizziness. any trauma to the head or spine, previous strokes, changes in any of their senses, and how they feel their memory and emotions are doing. We can also ask about their ability to care for themselves and their ADLs. We want to know how they are able to get to their appointments and to work, because all of this information helps us understand how their brain is working. And then in addition, we also want to know about any family history of strokes. When we formally assess mental status, we are assessing their level of consciousness, level of awareness, behavior, memory, and language. A lot of this information we get just from walking in the door and asking our interview questions. Level of consciousness normally is awake and alert. They have their eyes open, they are alert and watching what's going on in the room. Now, if you work night shift, your patients will probably be sleeping, so awake and alert might not be normal for 2 o'clock in the morning. Alterations in level of consciousness include lethargy, appearing drowsy or asleep most of the time, but can still wake up with stimuli like saying their name, and they can move their extremities. Stuporous means they're unconscious most of the time and must be shaken or shouted at to arouse. Comatose means they cannot be aroused even with painful stimuli. For level of awareness, we're assessing if they know what time it is, where they're at, who they are, what the situation is, and are they following commands. We would say they're awake and oriented times 5 because they know the answers to all these questions. If they don't know some of the answers, we need to investigate what could be occurring. For behavior, we're watching to see how they answer and how they behave to see if it's appropriate for the situation. Are they laughing when normal people would be crying? Are they emotional when they shouldn't be? Are they showing no emotions at all? Now, please be mindful that different cultures had different ways of showing emotions. So what we think may be abnormal may be totally normal for their culture. We want to assess their memory. We can tell them something and have them repeat it back to us. We can ask them to count forwards or backwards. We may ask them questions like, who's the president? When was their wedding anniversary? What's their spouse's name? Anything to let us know that they remember stuff. And when it comes to language, we're not assessing if they can speak English, although that's a very important assessment for us to do, but we're trying to see if they can read and speak simple words, letting us know that their brain is functioning. If we point to a picture and they call it a cat, and it's a picture of a dog, there might be some language issues in the brain. If needed, we may need to do more in-depth neurological testing, like checking cranial nerves. These are not common to our normal nursing assessment, so they would be above and beyond our normal. If we needed to check cranial nerves, we are assessing all 12 of them. This PowerPoint would be way too long if I described how to assess them all, so please refer to your book and the cranial nerve assessment video in your LWW Nursing Skills ebook. However, some of these are actually tested just by doing our assessments. We test ocular motor when we check for PERLA. We're checking facial when we have them smile and raise their eyebrows. We check acoustic when we ask them questions and the answers because we know they can hear us. We test accessory when we have them shrug their shoulders. I bet you didn't realize how many we do test over the last 8 PowerPoints. One other assessment we do, but normally we do it when we get the patient up to the chair, up to ambulate, is to assess their balance and gait and coordination. We stand them up, we see how well they balance and if they can walk. And if they have trouble doing these, there should be a neurological issue that could be causing it, or they might be having a muscular issue like weakness. Unless you work in orthopedics and neurology, most nurses aren't professionals at assessing these, and in that circumstance, we can consult our friends in physical therapy to help us do a fuller, in-depth assessment. Like with all the other body systems, there are age-related changes we need to discuss in the older adult. First, remember that their brain and nerves are old and things slow down as we get older. So their thought processes and verbal responses may be slower than normal. Allow them time to think and speak. Their senses may not work well, like hearing and vision, and even touch, smell, and taste. Their balance and coordination may be slower and less refined, so they may move slower and have balance issues. Add that to slower reflex responses, and older adults are fall risks. And older adults may appear confused in unfamiliar surroundings. They may not be confused at all, but they just may not realize or understand where they are at first. And this is it. This is the end of health assessment.